السلام عليكم. إبراهيم، تبي نبدأ؟
أهلين دكتور، إذا ممكن ننتظر شوي 5 minutes عشان الشباب من بعضهم لسه الغربية ما أخذت الصراحة. 5
أوكي.
minutes ممكن، إيش رأيك؟
طيب.
آه. دكتور وائل, I think we can start at 24 attendees.
Okay, excellent. طيب، السلام عليكم جميعا. Welcome to this ECG coding session. My name is Wael Alqarawy. I'm an electrophysiologist at King Saud University. So I just have few slides, and then essentially I have cases. If you look at the coding sheet, and hopefully by now you're familiar with this, most of the diagnoses are obvious, but I thought few can be rare to see. So I'm just gonna show you a few that are not very common ECG findings, and then we're gonna do cases. So what is the major finding here? You can text in the chat. I think we decided not to just to make it clear for the recording. write the answer on the chat box. So what's the major finding here? Sinus bradycardia. Okay. BH. Okay. So you guys are correct, except you haven't picked the diagnosis on the coding, and that's why I chose this. This is called giant T-wave inversion. So if you see, there's something here called giant inverted T-wave. Now there are other things, of course, but this is giant T-wave inversion. And you guys know what's the definition? When do you call it giant T-wave inversion? Yani not any inverted T wave is going to be giant. There has to be a definition. Yeah, Yazid is correct. More than 10 millimeter, correct. So when the amplitude is more than 10 millimeter, we call it giant. So this is a code that not a common ECG finding. So I just wanted to make sure you know about this. Okay, excellent. What about this one? Again, we rarely see this in real life, but it's one of the math. Yeah, so multifocal atrial tachycardia. And what's the difference between wandering pacemaker and MAT? The difference is the rate. So both will have different P wave morphology. If there's tachycardia, you call it MAT. Exactly. Rate is the defining feature. So if when you have multiple P wave morphologies, this could be MAT when there's tachycardia, or wandering pacemaker when the rate is not tachycardia. Yeah. Someone wrote sinus arrhythmia. That's a good thought. But in sinus arrhythmia, you must have sinus P wave morphology and constant morphology all the time. Good. What about this one? Just the major finding. Interpolated PVC. Excellent. And what's the definition of that? When do we say PVC is interpolated? Because it's one of the codes. Not sure why it's there, but it is. So when do we call it? Does not interrupt. Yeah, exactly. When the PVC does not interrupt the RR interval, meaning, so here, this RR interval preceding the PVC continues the same, as if there's no PVC. Because usually the PVC will interrupt the RR interval. When it doesn't, we call it interpolated. Okay. What about this one here? What do we call that? There are some clues with the arrows. Bidirectional VT. It's not, because the PVCs are same axis. Variant PAC, good thought, but these are actually not PACs. These are P waves marching through. The PVC comes as if it's conducted, but it's not. It's fused with the P. This is a very specific thing, extremely rare, not really clinically helpful, but it's in the coding sheet. So I just wanted to show it to you. Not Ashman, no. Parasystole, excellent. Yeah, parasystole. So what's parasystole? Ventricular parasystole, what does it mean? PVCs in regular interval. Yeah, means that the PVCs are essentially independent, dissociated from the underlying rhythm. So if you, like the lines here, if you take the interval between the PVC and the following PVC, it continues. كأنه ما في شيء underlying rhythm تحت. فإتس كأنها focus firing independent of the sinus rhythm or whatever rhythm is underlying. So this is called ventricular parasystole. Good. This one, what is this? This again a specific diagnosis on the coding sheet. Ditch. Yeah, Abdulaziz is correct. So this is a specific morphology of the ST depression due to digoxin. Reversed hockey stick. When you see it, it's probably due to ditch toxicity. Good. So all of the following, all of these were just sort of uncommon diagnoses or coding points on the sheet that I just wanted to make sure you guys know. The rest, I'm sure you know, the axis and the sinus and PACs and so on. So from now on, we're going to do it like the exam. So I'll show you an ECG, and then I want you to name 5 codes, and then we'll discuss it. So, so here, for example, for this ECG, I'll give you a minute. Think about what you would code and write it in the chat box. Okay, are we ready? So maybe if this is the coding sheet, maybe just stick with what's in the coding sheet itself. Sometimes we're just used to interpreting ECGs with things that are not on the code. So you guys mentioned AFib. That's one. LVH. lift axis deviation, STT changes secondary to hypertrophy, and then anything else? Because these are 4. Did anyone mention 5? No. Lift anterior fascicular block. Is it a code on the sheet? Yeah. Good. YVCT. Excellent. Yeah. So so why is it lift anterior fascicular block? When do we call it lift anterior fascicular block? Negative QRS in lead. When you have lift axis deviation, QR in 1 AVL, RS in lead 3 AVL. Yeah? Good. Excellent. Any question about this ECG? No? Good. Okay. There was a question. Why code lift axis deviation? Excellent question. You guys tell me why do we code lift axis deviation and lift anterior fascicular block? Can you have lift axis deviation without lift anterior fascicular block? Yes. Can you give me an example of that? No need to code lift axis deviation. True. If you have lift anterior fascicular block, you have lift axis deviation by definition, but for the coding, I think it's okay to code both. Okay, good. So moving on to the second ECG, I'll give you a minute to look at it. Okay, I think most of you got it. So you guys mentioned atrial fibrillation, with slow ventricular rate. Then you have low voltage in the limb lead. You have junctional escape rhythm. You have AV block complete. And then you can add digoxin toxicity. I think it's fair if you want to add that. You can add artifacts. I think that's also fair. So someone said long QT. Is the QT long? Not really. The corrected one is not going to be long because there's a bradycardia. Yeah, no, it's not. Yeah, agree. It's not prolonged. The corrected one. Okay. Any questions about this ECG? Just out of interest, in real life, if you see this in an old lady, what condition you think about? Shari, I'll come back to you. Sick sinus syndrome, no. Hypothyroidism could be, yeah, it's a good one. If I say old lady with HFpEF, amyloid, yeah, exactly. Amyloid is the one, and it's often missed. The low voltage, the AFib, you need to think about amyloid. Okay, let's go back. So, is it irregular? It's not irregular. And that's why there's AFib, but it's regular. So if you have AFib with regular ventricular rhythm, it must be complete heart block. This is how we make the diagnosis of complete heart block in the context of atrial fibrillation. Does that answer your question, Shari? Yeah, good. Is there any other questions? No. Sick sinus syndrome, this is, I think, what you meant, Hamid or Hamid, by SSS. Sick sinus syndrome means that the sinus node is dysfunctional. So it goes from AFib to sinus bradycardia. Here, you cannot make that diagnosis because we haven't seen sinus rhythm. So we don't really know. Okay, excellent. Moving on to the next ECG. Again, I'll give you a minute. Okay, good. So you guys mentioned complete heart block. That is correct. So I hope you can see that the P's and QRSs are dissociated. You see how here it's just coming closer and closer, so this is not conducted. The QRSs are regular. Yeah. So this is complete heart block. And then you see spikes, but you don't see capture. So this is failure to capture because you see a spike not followed by any electrical activity. not P, not QRS. This is, you know, that there's failure to capture. There's also failure to sense because it comes in a fixed interval. These QRSs are not changing the rate. Question, failure to capture V or A. You actually cannot tell, probably V because it's single, but because it's not capturing, there is no history, there is no chest X-ray, technically you cannot tell. But I would go with the V because that's, again, we rarely implant only single lead in the atrium. Yeah, so what to choose? I would choose the V. But I don't think anyone can fault you, but from the ECG point of view, you cannot tell because there is no capture. So we said complete heart block, failure to sense, failure to capture. Is there anything else we can code? Excellent. Junction escape. What else? Whenever you make a diagnosis of complete heart block, if you're running out of codes, you can use the AV block and then comment on the escape. So always remember it. Can we code sinus rhythm? That's a very good question. There is sinoatrial rhythm, which means the atrium is in sinus, which in real life, we always teach when you see complete heart block, you have to comment on the atrial rhythm. But the way it's in the code, when you say sinus rhythm, it means the ventricle is driven by the sinus rhythm. So I'm not sure that you can code sinus rhythm here because it would mean that the sinus is driving the beat. I don't know that for sure, but I worry that it might not count it as a correct answer. But in real life, this is what I would write: sinoatrial rhythm with complete heart block to make it different from someone complete heart block with AFib, for example. AV dissociation. The code says AV dissociation without AV block, but here there is AV block, so you cannot code that. Good. Can use with VT. Yeah, exactly. The AV dissociation, you can use it with VT, for example. What about inferior Q waves? Yeah, these are not pathologic, right? They're not 40 milliseconds in width. I think you have enough codes where you're sure they're correct, better than guessing with other things. Okay. Left atrial enlargement, I think that would be fair. I don't see clear STT, yeah, non-specific STT changes. Again, it might be correct, but there are other ones that are clearly correct, so I would go with these. For the previous issue, how can we differentiate between AFib with complete heart block versus sinus node arrest? Yeah, that's a very good question. So I'm going to go back to the previous ECG. How can we tell if this is AFib with complete heart block or sinus arrest with junctional escape? Yeah, like Abdulaziz is saying, the baseline, see, the baseline is not flat line. There are these fibrillation waves. So this is more obvious maybe in V2, for example. So this suggests AFib. Sometimes actually it's not that easy, especially on telemetry method, where you have some artifacts even when there's no AFib. But in ECG, you have the luxury of having 12 leads, so you're more likely to see these fibrillation waves to know that there's actually something happening in the atrium. Okay. Any questions about this ECG? Yeah, excellent. Okay. Next ECG. So I'm going to go back just one sec. Type of pacemaker here. This is a single pacemaker. This is all what you can tell from the ECG, not been given history or chest X-ray. You know that there is one lead. It's probably in the V because that's how we do it. But you can't really tell anything else. Okay. So this ECG, back to this ECG. Okay, I'm going to show you the code just so you remember the codes. Some of you are writing what we would write in real life, but you need to know the code attached to it. Okay, so you guys said sinus rhythm. This is correct. And then there is anterolateral ST elevation, right? This is what we would write in real life. But for the codes, you can code anterior, acute recent, septal, and lateral, right? So you get 3 codes. And then STT changes suggest myocardial ischemia. And there was a comment about lift axis deviation. What do you guys think? Is there lift axis deviation here? No, there is no lift axis deviation. Exactly. Why no? Because 1 is positive and 3 is negative. Yeah, 2 is positive. Exactly. So this is toward left, but not left. And you have enough codes anyways from the myocardial infarction thing. Okay, can we code STT changes while we code STEMI? Yeah, again, these codes are really, it's an exam thing. It's not real life. So I think if it's correct, no one will fault you. I don't do exam questions, so I don't know the details of how they assign points. But from the ECG point of view, this code is correct. Yes, it's expected, but you still, I think, just like the idea of lift axis deviation, lift anterior vesicular block, you can code both and you'll be correct. I don't think we have injury. Yeah, that's the American one. The American codes have injury and ischemia and all that garbage stuff. Here you don't have it, which is better. Good. Any questions about this ECG? Clear. Not for the coding, but just a quick teaching point. So what do you think about the T waves in the precordial leads? Hyperacute. Yeah, good for you. Exactly. So this is hyperacute T waves, which precede the ST segment elevation sometimes. And classically, you have two things. One, the base of the T is very broad, unlike hyperacute T wave, wide symmetrical. Yeah, good for you. Yeah, unlike the hyperkalemia one. Two, the ST segment is pulled. كأنه T is pulling the ST segment. You get that sense. This is usually just before you get the ST elevation. And then someone else commented on the reciprocal changes in the inferior leads, which is excellent. Which wall reciprocate to the inferior leads? يعني ال ST depression, yeah, lateral. Correct. Not anterior. You get sometimes people saying reciprocal changes from the anterior. Anterior do not reciprocate. Good. Excellent. Next ECG. Okay, so what did you guys write? Let me see. Sorry, I missed. So first degree, so right bundle with sinus tachy, first degree, left bundle, sinus tachy, ST, long QT, first degree. Okay. Left, okay, like that. Like 1, 2, 3, 4. No one mentioned 5 codes. Me, Abdulaziz Wayne. I missed it. I'm sure. Abdulaziz. Sinus tachy 1, complete 2, STT. You're right. Sorry, I missed it. Okay. Okay. Good. So sinus tachycardia, I think this is obvious. Left bundle branch block, first degree AV block, STT changes. هذول الواضحات. Then you could code artifact. I think that would be fair. You see in lead 2, for example. I think it's okay to code long QT, but in real life, is this long QT? When Abdulaziz? In real life, is this long QT? No, I've corrected. Exactly. Good for you. Why not? Um, not really because of tachycardia. How do you measure QT? من وين لوين? Yeah, white caress, exactly. Um, someone bro bridge or something. Yeah, white QRS, because of white QRS. QT is from the beginning of QRS to the end of T. So when you have wide QRS, of course, will increase the increase your QT artificially. So never comment on QT when there is wide QRS unless you correct for that. And there are ways, I'm not going to discuss them, but just so you know, because this in real life, this causes a lot of, you know, anxiety and so on. Okay, good. Any question about this ECG? With tachy long QT get shortened. Correct. So you have to correct for the heart rate, but the major thing here is the wide QRS that will mess up your QT. Good. No, oh yeah, is there lift axis deviation here? So you're right that 1 is positive, 3 UAVF negative, but we said look at lead 2. If it's positive, it's toward left, not left. So to have lift axis deviation, 2 has to be negative 2. Otherwise, you get toward left axis, but not left axis deviation. Good. Excellent. Next ECG. Okay, good. So most of you mentioned complete AV block, junction escape rhythm, inferior acute, posterior acute, STT changes. I think some mentioned sinus tachycardia. Again, I'm not sure for the exam purposes if that's going to be okay or not, but you are right. It is sinoatrial rhythm, sinoatrial tachycardia. Um, uh, Good. And someone mentioned long QT. Again, you have this because this is bradycardia, so the corrected QT is probably normal. So I would avoid that. So two things. Is this winky back will a complete heart block? Okay. What do you guys think? Complete heart block. Why is that? Why is it not winky back? AV dissociation. Yeah. Now, because we don't have rhythm strip, maybe that's why it was a bit confusing to some. But there are actually, it's not 2 to 1. There are way more P's than QRSs. 1, 2, 3, 4. Could have only P's. And then the PR is not fixed. Yeah. So that's why it's a complete heart block. So out of interest is, do you think this is RCA or left circ, and why? Okay, 1 vote for RCA. Or 2 votes for RCA. Oh my goodness. Everyone is saying RCA. Circ, thank you. Circ, okay. We're getting circs. This is probably circ, actually. So the heart block in RCA, what's the most common? Sultan is saying definitely circ. Looks like you're going to do interventional cardiology. Yeah. So the heart block in RCA usually or often is vaguely mediated. So you don't get this sinoatrial tachycardia. And then there are the other things, the posterior wall involvement and AVL sign and so on. Okay, good. Any questions about is there LVH? Is there LVH? Probably not. In 25, I don't think it goes to 35. So probably no LVH. How heart block and no regular RR and no regular PP. PPs are regular. And then this beat, you're right, might be a bit early. It's always better to have a rhythm strip to comment on regularity. But there's no groove beating. So you should have regular RR intervals in complete heart block with junctional escape rhythm, but you can have a beat that comes early from the escape. But when you have a long strip, the pattern shouldn't be a groove beating. Ventriculophasic, yeah, the PPs, the P interval where the QRS is in the middle can be a bit shorter than the other one, but usually it's fairly regular. So the difference is not huge. Okay. Any other questions about this ECG? This is, again, this is not for the exam, just for real life. So when you have complete heart block, why do you get sinoatrial tachycardia? Sympathetic, yeah, compensation. And that's why often you guys will see after we implant a pacemaker, the patient goes back to CCU or floor, and they're tracking a fast atrial rhythm, 100, 110. And often we get the consult, oh, is there something wrong? Is there a effusion, tamponade, and so on? It's just the sinus is still going fast, and with time, it will go back to the normal rate. So it's not uncommon, immediately post-pacing, you see fast heart rate. It's just the compensation. Good. Okay. Moving on to the next ECG. Why does the culprit is circ, not RCA? I don't want to make this a point. This is not for the exam. I would just say I'm trying to teach a point about the mechanism of AV block in RCA is often high vagal tone. not ischemia. You can have ischemia, but it's more common with left circ. That's all. Okay. Next ECG. Okay, good. So atrial fibrillation, ventricular pace, single PVC, left axis deviation, non-specific STT changes. Agree. And Abdulaziz, my go-to quote. I think this is a smart way of doing exams. Yani, you have to think about few codes where when you're stuck, things like artifact or non-specific, you go to. That's a good examineship skill. Good. Any question about this ECG? For the people going to the exam, you need to find yourself with the coding sheet. Yeah, I agree. Okay. We have here CRTD. Is this a CRTD? Probably not. Yeah, probably not. And I would say, one, it's not in the code anyways. Two, the way if we don't have an X-ray or history, the way we tell if it's CRT or not by the morphology of the QRS. I'm not gonna go into it now, but for the exam, really don't overthink it. Then there was a comment about repeat the codes. Yeah. So atrial fibrillation with slow ventricular response, paced ventricle, single PVC, left axis deviation, and non-specific STT changes. Okay, any other comments? Will be positive. Yeah. Is the baseline AFib? Yeah, baseline is AFib. Yeah, baseline is AFib. Okay. Any questions about this ECG? So this, by the way, the atrial rhythm gets missed a lot of time in paced ECGs. So people look at the pacing, comment on the pacing, and they forget to comment on the atrial rhythm. So for real life, not only for the exam, always ask yourself when you see a ventricular paced rhythm, what's going on in the atrium? Because you might miss AFib when patient is not anticoagulated and so on. Non-specific for ischemia or hypertrophy. You're talking about the coding. Yeah. I'm not sure again for the exam itself. I think If you write ST, non-specific STT wave changes, um, due to drug electrolyte imbalance might be okay. But again, don't quote me on the exam things. I don't do the exam. Intrinsic beat is junctional or ventricular. Um, intrinsic beat is junctional or ventricular. Yeah, this one. That's a very good observation. But is it actually an intrinsic or a PVC? Hard to know. So definitely for the exam, I wouldn't say anything. In real life, you would have to have the baseline ECG to compare it with. This could be an escape, yani a conducted beat that came earlier than the paced. That's why it was conducted. So the patient doesn't have complete heart block, just AFib with slow ventricular rate. And then you have one beat that comes early and it's conducted with aberrancy. This probably what's happening here. But technically, without knowing the baseline, you can't tell. Good. Any other questions about the ECG? All right. Next. Good. So I think you guys got even more than 5 codes. So you have ventricular tachycardia, AV dissociation without AV block, right bundle branch block complete, sinus rhythm, left axis deviation, um, inferior MI, all of these. There was a comment about prolonged QT. Again, I would be careful with that. The QRS is wide, so you can't really, it's probably actually not prolonged. Um, it might be okay for the exam, but if you have a more obvious code, I'd go with that. Okay. Any questions about this ECG? Yeah. Okay, good. Okay. Okay. So most of you got that this is VT, and when you have VT, you add AB dissociation. And this is actually a good example of AB dissociation. You see the P waves marching through. You see my mouse, the T here. So there's clear AB dissociation. And then axis. This is extreme axis. As we said, the go-to code is non-specific STT changes. Some of you mentioned right bundle. This is not right bundle, right? We only say right bundle when when it's conducted, a junctional beat or a sinus beat. Yeah. That's why even in real life, we say this is right bundle-like morphology, but it's not right bundle. You cannot code that because it's not conducted. What else I saw? Fascicular. It's a good thought. That's a very good thought. So Marwa is talking about a specific type of VT, fascicular VT. It could be, but probably not. Typically with fascicular VT, you have a typical right bundle morphology. Here you have monophasic R, but it could be. It's a good thought, and it's not in the coding. Okay, any other questions? Inferior MI. So you're right that there are Q waves, but these are during VT. So technically, you cannot comment on Qs being from ischemia when there's delta wave or VT, because the whole idea that Q waves indicate old MI is the scar, but when the activation is different, you cannot comment on it. Yeah, cannot comment, I agree. Good. R wave in V1, question mark. Yeah, there is R wave in V1. This is the morphology of the VT. Okay. RVH, again, just you have to be careful. Once you say this is VT, the morphology, you can describe it, but it doesn't translate into diagnosis. For example, you cannot say RVH because there is a prominent R wave in V1 more than 7 millimeter. Because this R wave came because of VT, where the VT is coming from, produced a prominent tall R wave in V1. All the criteria for RVH from V1 morphology is based on sinus rhythm. Yeah, just similar to what we said about the Q waves in inferior leads, for example. When you have VT with Q waves in the inferior leads, you cannot say there's evidence of old inferior MI, because these Q waves are not because of scar. This is because where the VT is coming from. Good. And then we said you can write sinus because the atrium is in sinus rhythm. So sinuatrial rhythm, the code doesn't have that specifically, but they might, when you write VT and sinus, it should be obvious that you're talking about the atrial rhythm. Good. Any questions about this one? No? Okay. Next ECG. Okay. Good. So you guys mentioned VT, AV dissociation. Some mentioned polymorphic VT, which is correct, but I don't think it's in the code. And then MI, anterior, lateral, STT changes with ischemia. And there are other things you could add. So you could add sinus rhythm. We have 2 beats of sinus rhythm. I think it's okay to say left bundle branch block. Although probably in real life it's not left bundle. But I think it's fair because it's wide. It's okay to say conduction delay, ventricular conduction delay. Wandering baseline is also, I think, fair one. So many codes for this one. Someone mentioned long QT again. Why cannot we comment on long QT? Wide QRS. Excellent. Yeah. No, bradycardia, you just need to correct for bradycardia. So we always correct bradycardia. But for the wide QRS, we often miss that. Although ischemia usually ischemia is a cause of long QT, but not always. Because the beat is following VT, we cannot comment. Yeah, definitely during VT you cannot comment. You only have 2 beats of sinus rhythm, so hard to comment. That's also very true. Comment. Yeah. So you don't have a stable RR. Dr. Marwa. Dr. Marwa is a world expert on QT and correction. So if I say anything wrong, Marwa, you correct me. Excellent. Any other questions? Not prolonged, clear in V6. Yeah, clear. Okay, good. Next ECG. Okay, some of you are writing correct diagnoses, but they're not in the code. I'm just going to show you the coding sheet. Okay. So you guys said sinus rhythm. This is correct. LVH, STT changes associated with hypertrophy. Giant T-wave inversion. We said what's the definition of giant T-wave inversion? We have a vote for more than 5 millimeter, more than 10. Yeah. For the giant T-wave, it's more than 10. More than 10. Yeah. Good. Excellent. Any questions about this ECG? This is, yeah, so in real life now, this is probably hypertroph. What type of hypertrophic cardiomyopathy? Apical. Yeah, good for you. Yeah, this is classic apical hypertrophic cardiomyopathy. Abdulaziz, you're mentioning wrong placement. Why do you think there's wrong placement? In AVR and AVL? Yeah, so if you switch AVR, AVL, the P wave should also change. Everything should change. What I meant is in AVR, you should have, if you switched it with AVL, you should have a positive P. And you don't really have a positive P here. He does have an abnormal P wave morphology. It looks like biphasic, but it's not negative. So probably not a lead misplacement. Can we code, oh, I missed this. Can we code LVH by voltage and ST? I think so. Yeah, I think so. Sometimes they add new codes. Oh, okay. Good to know. But probably the majority are old. So if you're familiar with these ones, that I hope it doesn't make a huge difference. Okay, any other questions about this ECG? Yeah, okay, excellent. Good. So agree sinus rhythm, right front branch block complete. I'll come back to RBH business. So there's left axis deviation, there's left anterior fascicular block, there's STT changes, there's MI anterior. Good, all these are correct. So let's just go back to your questions, your answers. So I wouldn't code RVH here because there is right bundle branch block. Yeah. No, in real life, you can still have findings of RVH in right bundle, but for the exam, especially if you have more obvious codes, I would avoid that. Right atrial enlargement, does it fulfill the criteria? Probably not. And again, there are more obvious codes. Posterior STEMI. Why do you say posterior STEMI, Chari? There's, if anything, there's ST elevation that precordial leads. There's no ST depression. So you're talking about the R wave in the V1. Yeah. No, but this is right bundle branch block. The R wave here is right bundle branch block. Okay. And what's unique about this right bundle branch block? Yani if you were to describe the waves in V1, is it RSR or Marwa? Excellent. The ischemic right bundle. Yeah, exactly. So this is QR. Yeah, Islam. Good. QR, exactly. So this QR is ischemic right bundle. Means you lost septal branches that supply the right bundle, and the right bundle is due to ischemia. It's not the usual conduction disease right bundle. Good. Was there another question? Why not intracranial hemorrhage? Because it doesn't look, يعني, intracranial hemorrhage can give you giant T-wave inversions, prolonged QT. You don't get this ischemic right bundle with ST elevation with intracranial hemorrhage. Antroseptal, yeah, correct, Ahmed. Antroseptal is correct. Good. Any questions about this this ECG? No. Okay. Okay, good. So you guys said sinus rhythm, VT. Some of you wrote polymorphic VT, which is absolutely correct, but it's not in the code. So just get used to reviewing the coding sheet. So VT, and we said when you have VT, you have AV dissociation, and then inferior, MI, recent, posterior is also correct, probably. I think it's a fair one to write. And then you can write STT changes due to ischemia. Yeah. PVC. I think if you code VT, I'm not sure if they're gonna be okay coding PVC and VT, because VT is essentially multiple PVCs. So, if you have other obvious codes, I'd probably avoid that. The one just at the beginning. Yeah, but there's always a PVC at the first beat of VT. I know what you mean, but I don't know from an exam point of view if they're going to be okay with it. But is it? But it is not similar to AVF. Islam, I don't know, but it is a sin beat, same beat in V6, sinus beat. Yeah, so essentially you have sinus, 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 and then polymorphic VT. And this is classic for ischemic polymorphic VT. Polymorphic VT could be due to long QT, so torsade, or ischemia. These are the two common causes. The way you differentiate between them, with torsade, usually you have PVC, pause, sinus, then PVC-inducing polymorphic VT. Whereas in ischemic polymorphic VT, you just have sinus, sinus, and then all of a sudden they go into polymorphic VT. Yeah, fusion. I don't think this is fusion, because the timing for it to be fusion, it has to be coming at the same time where you would expect the next sinus. This is much earlier than where you would expect the next sinus. Is there artifact in V1? No, I think it's just polymorph VT. I see what you're saying, but I think it's just a polymorph VT. Some of this might be artifact, just these small things, but the overall is just the polymorph VT changing axis. Any other questions about this ECG? You say it's torsade or VT? Yeah, so this is just for teaching purposes. So VT, when it's polymorphic, we divide them into torsade or just polymorphic VT. To call it torsade, you need to have long QT, and the initiation of polymorphic VT is preceded by long RR, then a PVC. So typically you have sinus beat, PVC, pause, sinus beat, PVC inducing polymorphic VT. This we call torsade. But polymorphic VT from ischemia doesn't have that pause and doesn't necessarily have long QT. You just have sinus مثل sinus, 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 and then all of a sudden you go into polymorphic VT. So for this one, I wouldn't call it torsade. Okay, any questions? No, all right. See you next. Good. So this is pre-excited AFib. So the codes, you can code pre-excitation delta wave. I don't think you can code short PR because it's atrial fibrillation, right? So there is actually no PR. But you can code pre-excitation, you can code atrial fibrillation with fast ventricular rate. You can also code WBW syndrome, right? You can also code right axis deviation, right? Because there's right axis deviation here. Yeah. Is here AVD in AVR? AV, is there AVD? AVD mean AV dissociation? There is no AV dissociation because the atrium is in atrial fibrillation. Right? So atrial fibrillation is this just chaos in the atrium. And the fact that you're saying it's conducted pre-excited AFib, it means it's associated. No delta wave in code sheet. Now, في هنا pre-excitation and then between brackets delta wave under AV conduction abnormalities. Okay, good. Any question about this ECG? So just for I think there are P's in AVR. So in AFib, you often can convince yourself that there are P waves, commonly in V1, but sometimes in other leads. These are just fibrillation waves. I guarantee you there are no P waves in AVR because the patient's in AFib. But even in AFib, if we go back, مثلا to previous examples. Oh, my mouse is not, yeah. خلينا نعطيك بس شوف واحدة من الأيفبس القديمة. Yeah, مثلا here, if there are lots of QRSs, you might see some of these and think that they're P waves, but they're not. So there are no P waves. نرجع لل ECG. Did you say we code AV dissociation? No, I don't think you can code AV dissociation. This is pre-excited AFib. Okay, just for teaching purposes, is this a high risk pathway or not, and why? Yes, Islam, correct. Why? RR less than 250. Excellent. Yeah, so you look at what's the closest, what's the shortest RR this pathway is able to conduct. So if it's less than 250, this is considered highest. Good. Excellent. Okay, so let's do the obvious ones. So sinus rhythm, posterior MI, recent, STT changes due to ischemia. I think we all agree on these three ones, right? And then you'll have to add two. There's really nothing very obvious, but let's go through the stuff you guys mentioned. I'm just going to start from the beginning. So Islam said old inferior. I think that's fair. In real life, though, are these pathologic Q waves? No, because they're not wide, right? Not so much, exactly. Yeah. The other things you guys mentioned, um, so prolonged QT, again, it's hard to measure QT here. Probably not prolonged, but for the exam, it might be fair to add. LVH, I think, is a fair one. Probably fulfill voltage criteria for LVH, so that's a good one. Can you comment? So RVH, do you think there is RVH? Well, first, why did there's a couple comments about RVH. Why are you guys thinking about RVH, Hina? Yeah, no RVH. No, because posterior MI. Exactly. You guys are thinking about this because of the prominent R wave in V1. This prominent R wave, what's the mechanism of it? Ischemia. Yeah. Q, exactly. Posterior Q. Mirror change of Q, exactly. Yeah. So there's no, I wouldn't say RVH. Okay. And then electrical alternance. So you are right that the voltage, the amplitude of the QRS changes. So if you follow my mouse, it comes down and then up. Is that, do we call that electrical alternance? Exactly. This is the respiration. This is change in respiration. Electrical alternance is beat to beat. Okay, beat to beat change in the amplitude. Good. Excellent. Any questions about this ECG? No? Okay, we'll move to this one. Okay. So let's do coding. So sinus rhythm. For the code, I think it's okay to call this incomplete right bundle branch block. There is early repole, benign. There is sinus arrhythmia. Do you guys see this? So this RR interval is longer than this, but the P wave morphology is similar. So this is what we talked about, the sinus arrhythmia. And then you're left, you have to add one more code. I think it's fair to add pericarditis, but in real life, this is probably not pericarditis. But I think it's okay for the code. So I have a couple of questions. Quadratic sign V4, V6. Yeah, it's not in the code, Nasser. It's not in the code. So you'll have to get used to knowing the codes in the sheet for the exam. Is it incomplete right bundle or IVCD? Yeah, when you have terminal R wave in V1, you see my mouse here. When you have this is what they mean by incomplete right bundle. Now, just for teaching purposes, there's really nothing like we shouldn't call things incomplete right bundle. There's nothing in EP is incomplete right bundle. It's just a morphology, often normal variant. But for the exam, this is what they mean. When you have terminal R wave in V1 and the QRS is less than 120 milliseconds, this is incomplete right bundle. You call it conduction delay when it doesn't fit this morphology, when the QRS is wide, but it doesn't fit right bundle or left bundle. I think because it's overcalling, you mean. Yeah, I agree. In real life, yeah, overcoding. Yeah, this is probably not pericarditis, but 5 codes sometimes can be challenging. So unless you have an obvious 5th code, I think you have to learn, as we discussed, to use these non-specific codes or double codes or things that could be correct for the exam, but not necessarily for real life. Good. Excellent. Any questions? In the exam, is it 5 codes or 4? Oh, I think 5, but again, don't quote me on anything about the exam. I was told 5, but you guys know better. Okay. Differences between epsilon versus early repole. Yeah, early repole means J point elevation. So you see here, for example, in V3, the J point is where the QRS meets the ST. And you see this point, it's elevated. This is early repole. It can have different shapes. For example, this one, there's a flat line, the ST segment. Whereas here, they meet here, and then the ST segment is down, right? So they can have different morphology, but the J point is elevated. Epsilon wave, which you see in which condition? The RBC, yeah. You see it in V1, epsilon wave. It's not common, it's rare. And you see a separate high frequency signal between QRS and T. It has nothing to do with being elevated or not. Often overcalled. So in real life, if you're calling something epsilon, you might be right, but more likely to be wrong. Okay, excellent. Any other questions about this ECG? All righty. think this might be last one, and then we can take a few questions. You guys try to put 5 codes just to get used to, assuming the exam is 5 codes, get in the habit of trying to write down 5 full codes, just like the exam. Okay. All right. Let's do this together. So, you guys coded AVNRT. I think that's fair. Why do you say this is AVNRT? Pseudo R-wave. Yeah, just for everyone. So what the standard is talking about is this looks like as if it's R wave, but these are P waves. How do you know why is this actually, why is it pseudo? Why is it not R wave? How do you know it's pseudo R wave? What's the best way to know? Compared to baseline, exactly. Compared to baseline. And this, the same thing in V1 is in the inferior leads. You see this? These are P waves, pseudo S wave. When you see that, it's likely AVNRT, so that's one code. And then retrograde P is a fair one, always with AVNRT. STT changes, I think, is a fair one. Low voltage, it fulfills, I think Islam mentioned it. Artifacts, you could code artifact. You see there are artifacts here. And there are some of the stuff you guys, let's just go back and see. I don't think it fulfills LVH criteria, right? Is there anything else you guys mentioned? No. Yeah. So these are the 5 codes. Any questions about this ECG? Okay, good. We have, okay, let me see if there's anything. Yeah, let's do this one and then we can stop truly this time. Okay. So I'm just going to show you the coding just for the pacemaker. You have A-sensed V-paced. This is probably the most accurate one. Okay. There is left axis deviation. I think we all agree. First degree AV block. I think it's fair one. Obviously, you guys know that this is not first degree AV block, right? We program the AV delay. Sinus rhythm. Again, what we mean by that is sinoatrial rhythm. The atrium is in sinus, but the ventricle is paced. And then you guys added some things like non-specific STT changes, left atrial enlargement. I think those are fair. Left bundle was mentioned. I don't think you can use left bundle. Again, every time you use right bundle or left bundle, it has to be conducted. It's VT or paced. That's why even in real life, we say left bundle-like morphology or the right bundle-like morphology, because they're not left or right bundle branch block. It has to be conducted to call it that. LVH, again, in real life, you can't do that, but in exam might be. Okay. So let's see some of the questions. So kindly explain. Yeah. So how do we know that this is A-sensed V-paced? Because we only see one pacing spike followed by QRS. So how did we know that this is actually a dual pacemaker? The reason, tracking, exactly. The reason is because this P followed by a fixed PR and then pacing spike, always. So this cannot be by chance. It means that this spike is tracking this P all the time. So this is how we know it's a dual. The first one is sensed because there's no pacing spike. The ventricle is paced because there's a pacing spike followed by wide QRS. So this is how you know it's a dual. A sense, V paced. Okay. What is meaning of? Let's go the coding and explain some of these things. So pacing, atrial paced. This is easy, right? It means there's a spike followed by P. Ventricular paced should be easy. Spike followed by QRS. A-sensed V paced we talked about. AV dual paced means both are paced. The case I showed, the P is not preceded by spike. That's why it's not dual paced. If there's two, if there are two spikes, spike P, but then PR, but spike QRS, this is AV dual paced. Demand, dual chamber. Demand means it's a backup. How do you know? You know if there's just intermittent pacing. So you have, let's say, a pause, spike P, and then PR, spike QRS, but then sinus tachycardia. This sinus tachycardia, there are no spikes because the pacemaker didn't need to do anything. But you know that there are dual chamber لأنه كان في beat paced. So this is where this code can be used. It's demand. It's not doing anything for most part because the intrinsic rate is high enough that the pacemaker didn't need to do anything. Any questions? I have 2 minutes. CRT for the exam, just code it as dual. Essentially, it's a dual. AV association with complete heart block or VT. AV association with for this code, يعني AV association in real life with both complete heart block and VT. This بالcoding sheet هنا حاطين AV dissociation between brackets without AV block. So use it with VT. Failure to capture, is it the same as failure to pace? No. So failure to capture means there is a spike, but the spike is not followed by anything. So the pacemaker is trying, but it's not capturing the myocardium. Failure to pace means there is no spike أصلا. But you have مثلا pacemaker, pace, but then there's a long pause or there's nothing happening. So you know that there is a pacemaker that failed to even pace. مثلا end of battery. هذا الفرق بينهم. Then it seems like failure to sense. No, failure to sense means you're pacing too much. There are actually intrinsic rhythm. Failure to sense when you have an underlying rhythm, but the pacemaker is just pacing. It's not seeing the underlying rhythm. So you see pacing spikes in between, كأنها ignoring the underlying rhythm. هنا failure to sense. Can we code AV block and AV dissociation? No, because they wrote without AV block in the coding sheet, Under sense, over pace. Correct. Yeah. If the spike came on T wave, not followed by paste, we can't say failure to pace. Yeah, that's a bit advanced. So the failure to capture can be physiologic. If you pace in the refractory period, we call it physiologic failure to capture. Which means, yes, I didn't capture, but actually not because of malfunction, because it's just happened to be in the refractory period. For the exam, I wouldn't overthink things. Yani if you see it, I think it's fair to say failure to capture, because you didn't say it's pathologic. You're just describing the ECG finding. What is failure to pace? Failure to pace معناته الpacemaker is not even trying to pace. ما في spike. يعني you have an ECG where you have pace, but then there is a long pause, nothing happening. Failure to capture, is it the same as failure to pace? Failure to capture, you have spike. Yeah, exactly. We need another session if possible. You have excellent teaching. Thank you. أبرك الساعات. Failure to pace is the same failure to pace. Yes, failure to pace is failure of output. Yeah, exactly. Okay. Time's up. الله يعطيكم العافية. موفقين إن شاء الله.